Saurabh Bhatia, and she's going to talk about the efficacy of narrowband UVB in progressive versus non-progressive, non-segmental vitiligo. So the floor is yours, please.
I would like to present a study on efficacy of narrowband UVB in progressive versus non-progressive, non-segmental vitiligo. This was a prospective comparative study. Now, as we know that vitiligo is an acquired idiopathic disorder of unknown etiology, it is characterized by progressive circumscribed depigmentation which involves the skin, mucosal surfaces and hair. Incidence ranges from around 0.1 to 2%, and it is because of T lymphocyte mediated destruction of melanocytes at the dermoepidermal junction. Progressive vitiligo is characterized by progressive depigmentation and appearance of new depigmented macules. Narrowband UVB with wavelength of 311 nanometers has been widely used for repigmentation. It inhibits the effect of cytotoxic T lymphocyte. It stimulates melanocyte migration from reservoir to melanoblastic cell lines. It converts filaggrin in the epidermis to cis-urocanic acid, leading to cutaneous immunosuppression. It increases anti-inflammatory cytokines like interleukin 10 and decreases inflammatory cytokines like interleukin 1A, 2, 5 and 6. The prime focus has always been on repigmentation with narrowband in vitiligo macules. However, the efficacy in arresting the progression of disease has not been studied. The aims of the present study was to evaluate the effect of narrowband UVB therapy in patients with non-segmental vitiligo divided into two subsets, progressive non-segmental vitiligo versus non-progressive non-segmental vitiligo. Also to assess the progression arrest in progressive vitiligo patients, to assess and compare the improvement in quality of life using Vitiligo Impact Scale 22, which is a specific scale to record the impact of vitiligo on quality of life. Additionally, to compare the adverse effects of narrowband UVB therapy in the two subsets. This was a comparative prospective observational study including patients of progressive and non-progressive vitiligo with age ranging from 15 to 60 years and body surface area more than 2%. Body surface area more than 50% or vitiligo variants like segmental, lip tip, mucosal vitiligo were excluded. In the end, we recruited 24 patients with progressive vitiligo and 9 patients with non-progressive vitiligo. After recruiting these 33 patients, they were evaluated at baseline and VIS2021 was calculated. Then every patient received narrowband using a whole body chamber starting from 0.28 joules per centimeter square with 10% increment every session for 2 to 3 sessions every week for 6 months. At the end of 6 months, every patient was evaluated using clinical photographs and the results were published. In the 24 patients who had progressive vitiligo, initially they were developing 5.88 new lesions per week, which over the course of 6 months decreased to 1.04 new lesions per week in the progressive vitiligo group. In those 24 patients with progressive disease, 19 patients, which is 79.2%, had halting or disease activity, while the rest 5 patients, or 20.8% of patients, were developing vitiligo at a slower pace as compared to baseline. At the end of 6 months of therapy, on comparing the final repigmentation achieved by patients in both of the groups, majority of the patients achieved repigmentation of 25 to 50% in their vitiligo macules. As we can see here, there was significant repigmentation of vitiligo macules and there was no development of newer macules or there was no increase in size of macules in patients with progressive disease. Similarly, significant repigmentation over the trunk and no new macules were developing over the course of 6 months. We can see on the acral sides also significant repigmentation and no newer lesions. A similar clinical picture was seen in patients with non-progressive vitiligo with good repigmentation of the vitiligo macules. Particularly over the trunk and face, there was significant repigmentation. In the end, when we compare this adverse effect profile between the two groups, adverse effects like well-defined erythema, burning, swelling, pain, or blistering due to therapy was not significant in difference between the two groups. However, when we compared lesional pruritus, which is itching in the vitiligo macules, and non-lesional pruritus, which is generalized itching, we found both of these parameters more in progressive vitiligo patients. We hypothesized that because of increased inflammatory activity, there was increased release of inflammatory mediators and cytokines leading to more itching in progressive vitiligo patients. On comparison of psychosocial impact of vitiligo among the two subsets, we found that there was significant reduction in psychosocial impact in both of the groups when compared to their baseline. However, when we compared these two groups with each other, there was no significant difference between the reduction in psychosocial impact. So, in the end, we would like to conclude that narrowband UVB has the potential to halt disease progression in progressive vitiligo. Also, the progressive vitiligo patients have more pruritus as compared to patients with non-progressive disease, and narrowband UVB significantly reduces psychosocial impact of vitiligo. And in September of this year, we published this study in Indian Dermatology Online Journal. Thank you for listening.
So thank you, Dr. Bhatia. Very interesting. And it confirms that narrowband UVB is a very good treatment, certainly for progressive vitiligo. We just had a technical problem and had the wrong video, but luckily we had your video now. Did you have the chance also to look at skin type and whether there is maybe an influence of skin type on the results?
Yeah, good evening, everyone. Am I audible?
Yes, yes.
So, yeah, we did record the skin type at the baseline using the Fitzpatrick scale, and majority of our patients had 3 type 4 skin, but there was no difference in the clinical response to phototherapy as compared to the 3 and 4 skin types. And the rest of the skin types was not enough to comment upon. So we did not find any difference between these 2 different skin types.
Okay. Another question would be, so this was narrowband UVB monotherapy. There were no other treatments combined?
No other treatment, monotherapy.
Okay, because often nowadays we combine topical and narrowband UVB to improve the outcomes. And what I saw that most of your patients achieved the 25 to 50% improvement,
Yes.
which is, I think, what we can expect after 6 months. But of course, we need to continue the treatment, and probably this will also be your approach for typically a year.
Perfect.
Yeah, yeah. Okay, and well, also interesting, the itching in the progressive group. I mean, probably we can understand. And from quite a number of studies, we know that itching is an issue in vitiligo, although we don't hear that often as a complaint in our outpatient clinics. But when we ask patients, it's about 20% what we hear from studies who will have itching complaints. But now it appears that also with narrowband UVB treatment, this increases, but especially in the progressive vitiligo patients. So that's interesting. Have you seen whether the itching improved during the narrowband UVB treatment, so that it was maybe more in the beginning and less at the end of the treatment?
Yeah. So initially, when the patients started to complain about itching, we thought that's basically because of increased narrowband exposure leading to dryness of skin. So most of the time, we used to prescribe them moisturizers only. But in few subset of patients, we had to prescribe antihistamines also. And the itching progressively increased while the narrowband was continued. And after the study period, when we stopped narrowband, there was improvement in itching. So we really think that this itching could be more a kind of a compounded effect of drying of skin due to narrowband and the increased inflammatory activity. This is just a hypothesis that we made, that because of these many factors, there was increase in itching. And there is always a baseline element of itching in progressive active vitiligo disease. And maybe on narrowband therapy, it just increased during the time that they were receiving narrowband. And when stopped, it might have reached to baseline, which the patients might have appreciated that as a decrease in itching. But I think it returned to baseline level of inflammatory activity. That has to be studied on biochemical levels to be more sure.
And could you discriminate whether the itching was limited to the lesions or whether it was on the whole body?
Well, when narrowband was started in our patients, the complaint of itching started from the lesions. And in the complete study, which we were not able to publish properly fully, but the data showed that the itching started around roughly 1 week prior to in the lesions as compared to the whole generalized itching. So that's why we hypothesize the involvement of more inflammatory markers around the periphery of or in the milieu of macules. That is why the itching might have started initially from the macular part, and then as the neuroband progressed, the generalized itching came into view. So that could be one clinical parameter to differentiate.
Okay, good. Thank you very much.